Hi, I'm Rich Sherman, Chairman of the Department of Psychophysiology at Saybrook University, and I'm presenting this introduction to pathopsychology from a psychophysiological perspective. Please notice that this is the first of two lectures, so please be sure you watch them both. Pathopsychology is the study of the biological basis of mental illness. It attempts to elucidate the genetic and neurological etiology behind psychological disorders, including schizophrenia, mood disorders, and anxiety disorders. It is not a branch of either forensic nor clinical psychology, nor pathology. Rather, it's a combination of all of them with a very strong emphasis on research. For the purposes of this introduction, we're not interested in all the areas of pathopsychology, but rather those which impact psychophysiological assessment and intervention. This material provides the basic knowledge of pathopsychology needed to properly assess psychophysiological dysfunctions and select the optimal interventions. Students must know the physiological bases of common psychological disorders and have sufficient skills in interviewing and assessment to determine whether patients are appropriate for psychophysiological interventions. They must be able to adequately assess normal people desiring training and optimal functioning to be reasonably certain that these people are appropriate for such training. This lecture explores some of the physiological problems which present themselves as behavioral disorders. The information in this talk is associated with at least 4 courses in the psychophysiology program: biological basis of behavior, the impact of hormones and perception on behavior, the impact of genetics on behavior, and psychophysiological recording, assessment, and intervention. I'm presenting a brief overview of a few of the more common problems rather than an in-depth exploration of most biological disorders presenting themselves as abnormal or unusual behaviors. Here are 3 key points to keep in mind. First, many disorders are actually a collection of behavioral symptoms which frequently co-occur. Frequently, these do not have well-defined reasons for happening. Examples include migraine headaches and phantom limb pain. Several totally independent underlying biological problems can result in the same collection of behavioral symptoms defining these disorders. Thus, some people with a behavioral disorder may have one or more physical reasons for having their collection of symptoms, while other people may have one or more psychological reasons, or any combination thereof. Physical and behavioral symptoms are magnified by stress and made more complex by psychological problems. Behavioral interventions can help and cure physically based behavioral problems, such as migraine and tension headaches. Because of the complex nature of disorders and their presentations, when performing psychophysiological assessments and interventions, you need to be able to identify physiological problems likely to cause the behavioral issue you're working with. For instance, UTI, urinary tract infections, underlie psychosis every once in a while. Thyroid problems underlie early dementia or depression. Respiration problems can underlie anxiety. Your diagnosis frequently needs to be based on more than a cluster of symptoms, as many different underlying problems lead to the same cluster. This means you frequently can't use DSM-5 diagnostic criteria alone, which are only a cluster of symptoms. for determining either diagnosis or progress through an intervention. Ignoring this means you could easily provide an ineffective treatment. Remember that NIH does not accept the DSM-5 as a valid diagnostic system. Reflex sympathetic dystrophy, male impotence, and phantom limb pain are three very significant problems which were considered to be primarily due to psychological problems as recently as 20 years ago. Some behavioral therapists are still treating these problems as if they are primarily caused by behavioral problems. There are literally thousands of articles by behavioral therapists, including psychiatrists and psychologists, attesting to the psychological causes of these problems. Phantom limb pain was supposed to be caused by an abnormal grief reaction. RSD was supposed to be caused by adolescent attachment problems to the mother. Male impotence was supposed to be related to all manner of psychological problems. Of course, for some it is. Well, these disorders are usually not caused by psychological problems. Of course, a wide variety of psychological problems can make physiologically based problems worse. Less often, psychological problems can cause them. Our lab studies of amputees show that they do not have more nor less psychological problems than the populations they come from. Other research groups have shown the same for people with RSD and male impotence. The vast majority of men with impotence problems don't know what normal erectile function is and are driven practically mad by the problem. Turns out that they were psychologically as normal or abnormal as anyone else before the problems began. Most, but not all men with impotence have vascular problems. When the problem is fixed physiologically, the psychological problems usually, but not always, disappear without any behavioral treatment. We found that phantom limb pain has different physical causes depending on how amputees describe their phantom pain. Burning and tingling descriptions correspond to blood flow problems in the residual limb. Cramping descriptions relate to actual microcramps in the residual limb. When we fixed the problems, the pain went away. The psychobabble was just that. Examples of physiological problems likely to cause the behavioral issues you're working with include urinary tract infections related to hypnosis, thyroid problems related to early dementia and depression, respiration problems related to anxiety, drug side effects resulting in anxiety, cognitive decline, memory loss, and etc. The medication side effect nightmare. We all know that medications frequently have side effects. What we frequently don't recognize is how common and severe behavioral side effects can be. These are very real and can be very serious. Some primary care providers make the mistake of assuming that a rare side effect is not affecting a particular patient because it's so rare. This can be a deadly error. Tertiary care providers understand the filtering effect of patients who don't respond to typical treatments winding up at a tertiary care facility because they're experiencing rare side effects which their primary care providers ignored. Our disjointed medical system frequently results in patients not consistently seeing the same primary care provider, so the current provider may assume that a previous provider has checked side effects. For example, atenolol is among the most common reasons patients report rapid onset of cognitive decline and memory loss. It also causes nightmares. Note that stopping atenolol frequently, but not always, does not result in memory return. You must check the side effects of every medication your patients are taking. If you're treating a condition which may be a side effect of one of the medications, you must take action. Never assume that a primary care provider has noticed the connection. The primary care provider may not even know that the patient has the behavioral side effect because the patient may not have told the primary care provider about the problem. Relationships between urinary tract infections and psychosis. There is no longer any doubt that chronic urinary tract infections predict psychosis. Thus, when you work with people who show psychotic symptoms, you must check to find out if they have chronic UTIs. Three large studies found, first, in a study of 349 people, UTI was found in 21% with non-affective psychosis, 18% with affective psychosis, 12% with alcohol use disorders, but only 3% in controls. After controlling for potential confounders, UTI was almost 11 times more likely in subjects with non-affective psychosis than controls. In a study of 272 people, 35% of acutely relapsed subjects versus 5% of stable outpatients and 3% of controls had UTI. Only 40% of subjects in the acute relapse group classified as having UTI were treated with antibiotics during hospitalization. After analyses were controlled for gender and smoking status, subjects in the acute relapse group were almost 29 times more likely to have a UTI than controls. In a sample of 57 acutely relapsed inpatients with schizophrenia, 35% of the patients had a UTI on admission, detected by urine analysis and urine microscopy. After controlling for effects of gender and smoking status, patients with schizophrenia were almost 29 times more likely to have a UTI than controls. By contrast, there was no association with UTI between a sample of 40 stable outpatients with schizophrenia and 39 controls. Furthermore, only 40% of the UTIs in acutely relapsed inpatients in the study were recognized and treated with antibiotics during hospitalization. Thyroid problems and early dementia and depression. Hypothyroidism and hyperthyroidism can cause very similar behavioral effects. These thyroid problems are very common, and of all the biologically based behavioral problems, these are the ones therapists must take the most care to watch for. Hypothyroidism and apparent early dementia. Hypothyroidism is clearly a common cause, not a correlate, of early dementia. This is not open to question any longer, as far too many studies have proven the relationship, and proper adjustment of thyroid hormone levels eliminates the problem if given in time. According to Medline, hypothyroidism, low levels of thyroid hormone, as well as thyrotoxicosis, very high levels of thyroid hormone in the body, both cause dementia. The problem is very common in people diagnosed with early dementia. One of the lowest incident rates was 4.4%, found in the huge San Paulo Aging and Health Study. The authors concluded that there is a consistent association among people with subclinical hyperthyroidism and dementia. Thyroid hormone disorders may cause confusion and changes in thinking or reasoning. These changes may be short-term or lasting. The early symptoms of dementia can include difficulty with tasks that take some thought but used to come easily, such as balancing a checkbook, playing games, and learning new information or routines, getting lost on familiar routes, language problems, such as trouble with names of familiar objects, losing interest in things previously enjoyed, flat mood, misplacing objects, personality changes, and loss of social skills, which can lead to inappropriate behaviors. As the dementia gets worse, symptoms are more obvious. Changing sleep patterns, often waking up at night, forgetting details about current events, forgetting events in one's life history, having difficulty doing basic tasks, such as preparing meals, choosing proper clothing or driving, having hallucinations, arguments, striking out, and behaving violently, more difficulty reading or writing, poor judgment and losing the ability to recognize danger, using the wrong word, not pronouncing words correctly, speaking in confusing sentences, withdrawing from social contact. Thyroid problems can be due to a change in the type of thyroid replacement medication used rather than a change in dosage. Blood tests for thyroid hormone levels can be very misleading. An endocrinologist may be needed to properly evaluate thyroid function. The most common thyroid function tests are total or free T4. That's the main thyroid hormone in your blood. TSH, the hormone from the pituitary gland that stimulates the thyroid to produce T4. T3 is also included sometimes. Other thyroid tests include T3 resin uptake and a thyroid scan. Are you treating anybody with any of these symptoms? If so, have you checked or have you had checked for proper thyroid functioning? Did an endocrinologist determine which test to give and interpret the results? If you're treating someone for symptoms of dementia and have not ensured that thyroid function has been properly and adequately checked, you are not only behaving unethically, you are potentially causing irreversible, severe damage to your patient. Biological bases of anxiety. Many diseases, normally ingested substances, food, drinks, etc., and prescribed and over-the-counter medications can cause intense disabling anxiety among people particularly sensitive to the substances. Dietary, some vitamin deficiencies, too much caffeine, monosodium glutamate, magnesium, diseases, anemia, secreting tumors, neurologic conditions, and metabolic problems, including Cushing's disease. Hypoglycemia, a drop in blood sugar, causes extreme reactions in the nervous systems, including feelings of anxiety, confusion, and even panic attacks. Breathing disorders and anxiety. Dick Gevirtz and many others have determined that many people with diagnoses of anxiety disorder actually have breathing disorders. When the breathing disorder is corrected, the anxiety goes away without further intervention. So, we need to adequately assess breathing patterns as part of any evaluation of patients presenting with a primary diagnosis of anxiety. Remember that we can always find a psychological reason for a patient to be anxious, but it really helps if we can identify an underlying reason, regardless of whether those reasons are behavioral or physiological. Numerous studies have identified specific genetic abnormalities underlying presentation of anxiety, not accounted for by any non-genetic internal processes nor external events. 3 such studies are summarized on the next 2 slides. Next, we're going to spend a few minutes talking about the immune system and behavior. There's lots of talk about the immune system having an impact on behavior. Many researchers feel that exposure to infectious agents or our immune responses to them can increase the odds that people will get a mental illness. There is now actually more than circumstantial evidence supporting these assertions. For example, about 1% of people develop schizophrenic symptoms sometime during their lives. However, if the mother had the flu in early to mid pregnancy, that rate increases to somewhere about 3 to 5%. Mice born to mothers who had the flu during pregnancy are more fearful of new environments than other mice. Their brains are different than those of other mice. There is some evidence that prenatal infections with rubella and herpes may increase the odds of a child developing autism. Infection with streptococcus is correlated with sudden onset of childhood OCD. The infection itself may not produce the problems. It could be the immune response to the infection. Cytokinins can cross the placenta-fetus barrier. Increased cytokinin production can affect a fetus's brain development. Mothers with higher levels of cytokinins are more likely to give birth to schizophrenic kids. Genetic studies show that genes linked to increased likelihood of schizophrenia are involved with production of cytokinins. Now I'm going to tell you just a little bit about parasites and behavior. The parasite Toxoplasma gondii infects a large portion of the population, perhaps up to 40% in some areas of the world. Rodents infected with this disorder lose their fear of cats. Humans born of mothers infected with T. gondii have about 2.5 times the rate of schizophrenia relative to those born of mothers not infected. Infected adults have been shown to be relatively more insecure and neurotic. This parasite can cross the blood-brain barrier. The parasite causes increased dopamine production in the fetus and adult, which is related to schizophrenia. It's an easy parasite to test for, and it's well worth doing. Genetic causes of abnormal behaviors. There have been many excellent studies which evaluated the behaviors of identical and fraternal twins raised apart. Among the best was the 1990 University of Minnesota study of twins reared apart. They had 59 pairs of identical twins and 47 pairs of fraternal twins. The identical twins were very similar in IQ and personality, regardless of whether they were raised apart or together. IQ correlates were 0.85 out of 1 for those reared together and 0.70 for those raised apart. Note that numerous studies have now shown that attempts to increase IQ by rearing kids in enriched environments or with supposed intellectual foster and adoptive families have failed to result in any lasting or academically significant increase in IQ. Not all behaviors which run in families are inherited genetically. For example, twin studies show that bulimia and childhood disabling fatigue run in families but are not genetically inherited. However, many behaviors are. For example, schizophrenia, autism, unipolar manic depressive disorder, ADHD, and cognitive ability are, at least to some extent, genetic. There have now been a number of studies looking at children's behaviors influenced by genetics. This is one of the best of the earlier studies. Towers et al. Used 6 subscales of the child behavior checklist teacher report form. They had 373 same-sex twin and sibling pairs of adolescents in the study. So this is pretty robust. They found that attention and social problems were more related to genetics than environment. Externalizing behaviors, like yelling at other people, were largely a result of many different genes working together. Anxious, depressed, attention problems, withdrawn, and social problem behaviors were highly related to genetics with less environmental impact on their expression. They controlled for a lot of different factors in this study. For example, non-divorced versus step families had very little effect on the outcome. Many of the studies have concentrated on inheritance of violent behavior and juvenile delinquency. Quite frankly, I am profoundly disturbed by the results of these studies. In a number of the early studies from the 2000s, which have now been replicated ad nauseum, early onset delinquency is more genetic than late onset delinquency based on studies of 11-year-old twins. In Taylor's study, there were 36 pairs of early starters, 86 pairs of late starters, and 25 controls. Vandenoord's study looked at 446 monozygotic, 912 dizygotic pairs of 3-year-old twins. They found that 37% of negative violent behaviors were due to genetics. 51% were due to shared environment, and 11% due to non-shared environment. In other words, we've got at least a 37% result of behavior due to genetics. Alsbrook did a review of all the twin studies from around 2000, which showed that there was literally universal support for genetic components of violent behavior among young children. Genetic studies have related specific combination of alleles on different genes to propensity to exhibit violent behavior. For example, Guo has conducted a series of studies showing that about 1% of people have any combination of 3 genes giving a propensity to violence. Symptoms of demonic possession related to genetic abnormalities. Please don't laugh about this. The topic actually does relate to genetics. Tales of demonic possession make for great movies and send chills down our backs. There are more than sufficient well-verified cases of people, almost always adolescent females, who behave as though they are possessed. Note that this does not include the special effects of floating, twisting the head all the way around, etc., that you see in the movies. It is very possible that many of these people have terrible psychological problems, or maybe they are possessed. However, there's a well-defined medical reason some young women seem possessed by demons. There's a type of encephalitis that's very, very rare, that's associated with acute psychosis and catatonia. And this tends to produce many of the symptoms that would be associated with demonic possession. Patients develop a multi-stage illness that progresses from initial psychiatric symptoms to memory disturbance, seizures, dyskinesia, and catatonia. Psychiatric manifestations include anxiety, mania, social withdrawal, and psychosis, including delusions, hallucinations, and disorganized behavior. The disorder is more common in young females, about 80%. About half also have an underlying ovarian teratoma. Treatment involves immunosuppression, with steroids and intravenous immunoglobulin considered as first-line interventions. The treatment is about 70% successful in relieving the behavioral symptoms. So, if you're working with a young lady that's apparently possessed, make sure they don't have a genetic problem before you get going. Hormonal imbalances underlying abnormal behaviors. I'm starting off this lecture with a brief discussion of hormones and depression. According to Nelson, depression is often evoked by endocrine changes. The symptoms of depression include reduced mood, low self-esteem, general fatigue, feelings of guilt, sleep disturbances, anger, irritability, and reductions in sexual motivation and food consumption. Exogenous versus endogenous depression. Many depressed people have obvious reasons to be depressed, such as death of a loved one, a failed business, etc. Most folks recover gradually, some with psychological support and some without it. A good social support network is crucial to recovery. It's possible that this exogenous depression causes changes in hormones, but this really has not been proven. Other people are very depressed, but there's no obvious reason for such deep depression. This endogenous depression used to be ascribed to such causes as a wandering uterus. Turns out that the uterus doesn't wander much, but there are lots of changes in the body's hormonal control system which do go out of whack, which in turn do cause depression. Many diseases seem to cause depression by altering hormonal balances, entirely separate from people's natural reaction of becoming depressed because they're sick. It could be that some environmental event originally triggered a change in hormones, but again, there isn't evidence supporting this idea. Both high and low levels of some hormones, such as cortisol, can cause the same depressive symptoms. According to Nelson, TRH and TSH administration can ameliorate depressive symptoms. Abnormalities in amounts of GH and prolactin are linked to depression. About half of depressed patients have elevated cortisol production. Estrogen deficits are associated with depression, and estrogen replacement therapy can elevate mood in depressed women. Nelson concludes that depressed patients may have experienced an alteration in the neuroendocrine mechanisms underlying the feedback control systems of the HPA axis. Of crucial importance, It is not clear whether this is a cause or a result of the depression. A great deal of research is being conducted on the role of fat, and especially fat cells among obese people, in relation to a variety of behaviors. Here's a quote from a paper Sam Kohlenberg wrote for one of our courses that shows how obesity and depression are related, not because people who are obese get depressed, but the other way around. The special case of postpartum depression. There are at least two conflicting views on the relationship between the endocrine system and postpartum depression. Nelson feels that postpartum depression probably reflects adjustments to parenting rather than endocrine changes. He also suggests that exposure to high steroid concentrations may account for some of the psychological symptoms associated with postpartum depression, just as happens with abuse of anabolic steroids. Many other scientists feel that postpartum depression is very much related to the endocrine system. Much of the quite convincing evidence supporting this view is summarized on the next few slides. The Mayo Clinic's website states, after childbirth, a dramatic drop in hormones, estrogen and progesterone, in your body may contribute to postpartum depression. Other hormones produced by your thyroid gland also may drop sharply, which can leave you feeling tired, sluggish, and depressed. Changes in your blood volume, blood pressure, immune system, and metabolism can contribute to fatigue and mood swings. To me, that's a very good summary. My conclusion is that, sadly, there's still no real conclusion about whether hormones are actually a cause or effect of postpartum depression. This lecture is continued on the next slide set.